Hello guys, how you doing? My name is Dr. Daniel Mbom. I'm an emergency medicine attendant at University of South Florida's Emergency Medicine Residency Program. And today, we're going to be going over the basics of lung ultrasound. Without further ado, let's get this party started. I have no disclosures. We're going to be going over some clinical scenarios when you would use lung ultrasound. We're also going to be going over appropriate probe selection for lung ultrasound, what the optimal patient positioning is, basic lung anatomy, probe placement, key ultrasound settings, and lastly, we're going to be able to be distinguishing between normal and pathological ultrasound findings. How many times in your clinical practice have you seen a patient who comes in with dyspnea, tachypnea, and chest pain? Lung ultrasound can be used to diagnose a variety of lung conditions. These are just some of the lung conditions that you're going to be able to diagnose using lung ultrasound. So now this begs the question, what is the appropriate probe for you to use when you're doing lung ultrasound sonography? Is it the linear probe all the way to the left of the screen, the curvilinear probe, the phased array, or an all-in-one probe like the butterfly, which is all the way to the right-hand side of the screen? Let's go over the advantages and disadvantages of each one. Let's start with the linear probe. The linear probe has a really high frequency. What these translates to is really good image quality. However, it sacrifices depth. It has really poor penetration. The linear probe can go all the way to 6 to 8 centimeters in depth. Next, the curvilinear probe. Curvilinear probe has very low frequency. What this translates to is really good penetration. Okay, it can go all the way up to about 25 centimeters. So really good penetration. It also has a really good footprint. So it gives you a lot of real estate. However, because the frequency is low, it sacrifices resolution. Lastly, the phased array probe. Just like the curvilinear, it also has low frequency, which means it can give you a lot of depth, better penetrability, but it also sacrifices resolution. An advantage of this over the curvilinear is it has a smaller footprint. So if you're trying to get in between ribs, shadow, or you're not really worried about a lot of real estate, this is a good one to use. So now, back to the question, which ultrasound probe are you going to use for your lung evaluation? Now, that's a trick question because the right answer is actually all of them. You could use each one. You could start with one and switch to the other. It all depends on what you're looking for. If you're looking for very superficial structures like the musculature or the pleura, the linear probe will be the best one to use. If you're trying to evaluate deeper structures and you want a wider footprint, curvilinear will be the best way to go. If you want to evaluate deeper structures and you're not worried about a lot of real estate, you want to get in between those pesky ribs, then guess what? The phased array probe is the best one to use. Or you can start with, for example, your linear array probe to evaluate the pleura and then switch to the curvilinear or the phased array for deeper structures. The optimal patient positioning for lung ultrasound evaluation is either supine or upright. In the ED, we usually have our patient supine at 0 degrees. This is an example of optimal patient positioning, and we'll go over why that's important a little bit later during the lecture. Now, going over lung ultrasound anatomy, we're going to start with the top right-hand corner of the screen, all right? We're going to divide it into hemibody. We have our left and our right side. Left side is divided into the upper and lower lobes, similar to the right side. Where this is different is concerning the anterior portion of the chest. On the anterior portion, the right side has 3 lobes, the left side has 2 lobes. So when you're scanning the left side, for the most part, you'll be getting the left upper lobe and a little sliver of the left lower lobe. Whereas when you're scanning the right side, you'll be getting a lot of the right upper lobe. You have a sliver of the right middle lobe and a sliver of the right lower lobe. Similar when we're scanning the lateral aspects of either the left or the right, you're going to be getting either the left upper or the left lower. But on the right side, you're still going to get a sliver of the right middle lobe. Concerning optimal probe position, you want your indicator to point towards the patient's head, and you want to use a mowing the lawn approach. The mowing the lawn approach is a colloquial term I made up just to mean mow the lawn on the patient's body, for lack of a better term. All right. Depending on what resource you use to study long ultrasounds, whether you're using the different studies, different articles, they're anywhere from 3 points all the way to over 28 different lung points or zones. All right. How are you going to remember which one to do? All you need to do is start by the sternum, either to the left or the right, and slowly go down, similar way to how you would mow a lawn. Easy, right? If you do it that way, you don't need to remember whether there are 3 long zones, 3 long points, 28 long zones, 28 long points. None of that matters because you're going to start by the sternum, either to the left or the right, and you're going to go in a lawnmower approach till you get to the posterior lateral aspect of the lung. That way, you don't really need to know how many long points or zones you need to scan. This is just a video showing how you would position your hand. And right here is the probe indicator. So the indicator is towards the patient's head. The reason why I'm putting my fingers here is just to stabilize the probe, because you're going to be looking at your ultrasound monitor while you're slowly going down. And you're just literally sliding slowly down, and then you're going to turn all the way and slide back up. Easy, right? Now let's go over a little bit of lung pneumology. We're going to go over what the lung preset is, how that's different from the abdominal preset and when to use one versus the other, and to go over what M mode is and how you would use it. So the first video is showing the ultrasound machine in RED and how you get to the lung preset. And how you get to the lung preset specifically using the linear probe. So this is the ultrasound machine we have in the ED. To get to the lung setting, if you're going in the linear, you hit that, you hit lung, and now you're in the lung setting, okay? The next video is showing how to get to the lung preset using the curvilinear probe. For the curvilinear, you hit the curvilinear, and if you want the lung setting on the curvilinear, and you're in the lung setting. This next video is going over how to get to the abdominal preset on the curvilinear probe. If you want the abdominal preset on the curvilinear, now you're on the abdominal preset. And this last video is going over how to use M mode on the linear transducer. All right, so we're on the lung preset. If you want to get to M mode, you literally hit the M mode. This line comes up, and then you hit it again. And then it switches to the M mode preset. All right, so now I just hit you with how to get to different presets and M mode. But that begs the question, what is M mode? M mode means motion mode. It is a mode that you can use to assess for lung motion over time. So the first thing you do, like the video says, now every ultrasound machine is different. So you just need to figure out where that button is on your ultrasound machine. So in this ultrasound machine is right there. Once you hit it, it produces this vertical line that goes down. Now you put the line is able to be freely moved. You put the line over your structure of interest. In this case, if we're doing lung ultrasound, it's probably going to be over the pleura, right? So once you put it over the pleura, you hit it again, and it gives you motion over time. And we're going to talk about that in subsequent slides and how that is effective in assessing certain lung pathology, normal versus abnormal, and when you would use it. Now, let's get into normal lung ultrasound. Yay! All right, so this is an example of what the normal lung should look like. Okay, this is a curvilinear probe, so you have a nice curvilinear footprint. You have nice wide view and real estate here. We're seeing a dark structure with some shadowing. This structure is the rib with rib shadowing. Over on the other side, we're seeing the same thing, rib with rib shadowing. And this first bright line or hyperechoic line is the pleura. So the pleura is going to be the first line, a little bit lower than where you find the ribs, okay? And in normal lungs, you should see almost like equidistant to the pleura between the ultrasound probe and the pleura. You're going to see the same distance, another white line, and equidistant, you'll see another white line. These are called A lines. These are reverberation artifacts that is created by the lung ultrasound on the pleura. Now, the thing is, the whole point of using the lung preset to evaluate lung pathology or normal lungs is you want those artifacts there, because those artifacts allow you to be able to see things like A lines and appropriately evaluate them. The main difference between the lung preset and the other presets is in the other presets, they take away those artifacts to give you a way better image. Whereas in the lung preset, it keeps those artifacts in, and sometimes the images look way grainier. Or grittier compared to the other the other presets that are not the lung presets. So this is just another example of A lines in normal lung. So again, we're seeing ribs with rib shadow, ribs with rib shadow. We're seeing the pleural line, and we also saw the nice reverberation artifact that we call A lines. So this is just another example of the same thing. Here we see a B line. We're going to go over what it means in subsequent slide and why this is normal in this case, but it could also be abnormal in other cases. Same thing here as we're going through. We're seeing the pleura, we're seeing A lines, and we're also seeing motion artifact right at the level of the pleura. We're going to go over it on the subsequent slide because it zooms into the pleura so we can actually truly assess that. So here you're actually seeing this motion artifact. People call it many different things. One common term is ants marching down the screen. Okay. Not that it looks like ants, but you can clearly see that there is motion here. So rib shadow, and motion artifact along that pleural line. This is what a normal lung should look like. So this is just another example. Rib shadow, nice motion artifact, A lines, rib shadow. So again, normal lung. We're going over different ones to show you what normal look like. Because if you know what normal is and you see abnormal, you're like, there's a problem here. Now this is grainy echo texture, but I'm seeing motion artifact. I'm seeing rib and rib shadow and motion artifact. So again, normal lung. This is using the linear probe, rib shadow, motion artifact. That motion artifact is caused by the sliding of the parietal pleura on the visceral pleura. And that is what creates that ants marching down the screen motion artifact that we typically see in normal lung. That is indicative of normal lung sliding. Now, there are cases where you are not able to truly tell while looking at the pleura whether there is that motion artifact or normal lung sliding. In that case, it's useful to be able to use M mode. So like we said, we're seeing this nice vertical line. We put it over our structure of interest, which is the pleura here. So here we have the rib with rib shadow. On the other side, there's another rib with rib shadow. We can't really see it clearly, but this is our structure of interest. You hit that MO button again, and it generates this. If you see the pleura here, if we go all the way to the side, the pleural line is almost at a level of 3 centimeters if we look over here for our depth. So down on this section that's generated by the MO tracing, this is the pleural line, also at the level of 3 centimeters. Now, you can tell that there's a difference between the top half of this screen here and the bottom half. This top half here has a nice horizontal, clean texture, whereas the bottom part is gritty. This grittiness is motion artifact, and that tells you that there's normal lung sliding. So if you're confused and you're like, I cannot tell, just by looking at the pleural line, whether there's that motion artifact indicative of lung sliding, you hit the MO tracing. And if you see a difference between the level above the pleura and the level below the pleura, then that can confirm that there is motion artifact indicative of lung sliding. There is a specific name for this sign. It is called the seashore sign. Below the level of the pleura, it has that sandy, gritty echo texture, so they call it the beach. Above the level of the pleura, they give it names like ocean or sky. All you just need to know is that there is a difference between the level above the pleura and the level below the pleura. If the level below the pleura is nice and gritty or has that gritty or sandy or grainy echo texture, then that tells you that there is motion there, that motion artifact indicative of normal lung sliding. Now let's go over the Blue Protocol. The Blue Protocol was a protocol made by Dr. Lichtenstein. It's an acronym for bedside lung ultrasound in emergency. In 2008, Lichtenstein and his colleagues wanted to come up with a quick, easy way of diagnosing different lung pathologies in critical care patients. They were trying to make a systematic, easy way to come up with these diagnoses, and they therefore created the Blue Protocol. The Blue Protocol starts with whether or not you see lung sliding when you do the lung ultrasound, and then based on that, assesses to see what kind of profile that you see when doing the lung ultrasound. The A profile is when there is lung sliding and A lines in bilateral lung field. The B profile is when you have lung sliding and B lines in bilateral lung fields. The AB profile is when you have A lines in one lung zone or, one hemithorax and focal or B lines in the other hemithorax. A C profile is when you have consolidation in one lung zone. An A prime profile is when you have no lung sliding and you have A lines in a lung zone. A B prime profile is when you have no lung sliding and B lines. And then based on those profiles, they were able to come up with different common diagnoses. All right, now let's get into it. So, what are B lines? B lines are lines that are generated at the pleura and go all the way down to the bottom of the screen. Earlier, when I was showing you a normal lung ultrasound, there seemed to be a line that was very similar to this. It started all the way at the pleura and it went all the way down. However, that was normal. The difference between that and this is, first of all, you see that there is a lot of B lines in this case. B lines are pathologic when they're more than 3, and in case of really diffuse, where you see them everywhere in bilateral lung fields, it can be indicative of a diagnosis we're going to go over shortly. So this slide is just showing the same thing as the previous slide. The main difference is our depth indicator here. You can see that we're more than 20 centimeters, and these lines go all the way down to the bottom of the screen. This is really important because there is another line called Z line, different from B line. Z line looks exactly the same as B line, but it does not go all the way to the bottom of the screen. It starts at the top and just fizzles out. So it is really important for you to put optimal depth or enough depth to be able to see whether the line is generated at the pleura and goes all the way to the bottom. Then that begs the question, what is optimal depth? Optimal depth is 12 centimeters or more. That gives you more than enough depth to be able to see whether the lines continue. Okay, so 12 centimeters or more. Again, this is just another example of B lines. Now, when B lines are diffuse and B lines are plethoric, and you see B lines in bilateral lung fields, the more B lines you have, the more confluent they are. So they start individually, and as you have more and more, they start to join together to form one big, massive B line that goes all the way to the bottom of the screen. Okay. This is another example, starting at the top and going all the way to the bottom. And as the pleural line, the visceral and parietal pleura slide on each other, you see the B lines move. So your patient comes in. Your patient is tachycardic, tachypnic, and dyspneic, right? You throw the ultrasound probe on their chest. They have lung sliding. You then see diffuse B lines in bilateral lung fields. What's your diagnosis? Pulmonary edema. So that takes us back here. Per the Blue Protocol, there was lung sliding in our patient. Okay, this patient had a B profile. In the bilateral lung fields, the patient had a lot of B lines. So they were diagnosed with pulmonary edema. Next, A-lines. Like we talked about, A-lines are that reverberation artifact that starts at the pleural line and are equidistant. They could stay or just sort of fizzle out as they go down. So this is just a good example of A-line. We're seeing nice motion artifact and we're seeing that reverberation going down. So we then proceed to do a DVT scan. And we're seeing something right here in the vessel. The vessel does not compress. That vein, the walls of the vein are not touching. All right. You then turn it sagittal, and you're still seeing something in the vein, which is why the walls are not touching. While you're doing your lung ultrasound, you see this, a little pleural wedge that comes in and out of focus. This is a still photo of the nice triangular pleural wedge. So what's your diagnosis? In this patient who comes in, dyspneic, tachycardic, tachypneic, the patient has lung sliding, the patient has A-lines in the bilateral lung fields. You do a DVT, ultrasound scan. It is positive. You do see a clot. What's the diagnosis? PE. Now, hold on. This is a lung ultrasound lecture. So why on earth are we going over DVT scan? And we just diagnosed the patient with PE. Aren't there better ways to diagnose PE like a cardiac ultrasound? I know. The reason why I'm breaking this down this way is because per Liechtenstein's Blue Protocol, this is what they did. They did not do a cardiac ultrasound for evaluation of PE. They recommended that you could do that. However, they did not do that. And since we're going over the Blue Protocol specifically, that's why I am using this algorithm, because that is what they did in that study. So please do not cut my head off. The how to evaluate for PEs using cardiac ultrasound is a completely different lecture that we can go over. Also, how to appropriately evaluate for DVTs is another lecture. We're just pulling pieces that were done in the Blue Protocol and going over them in this lecture, okay? So please do not cut my head off for doing it that way. So again, this is another example of A-lines. We're seeing lung sliding and that reverberation artifact. We're seeing rib and rib shadow, rib and rib shadow. However, in this patient, we're doing the DVT scan. You compress so well and so hard that both the arteries and the veins completely collapse. They're touching. So this patient has no DVT. And then we get to the Plaps point. Plaps is an acronym that stands for posterior lateral alveolar or pleural syndrome. This point is the intersection between the posterior axillary line and the lower blue point line. I just gave you a whole lot of acronyms and talking about lower blue points. Now let's get into what that is. So in this study, if you take both hands and place one, part of one hand inferior to the clavicle and the other hand together, excluding the thumbs, the middle portion of your upper hand is called the upper blue point. The middle portion of the lower hand is called the lower blue point. And the intersection, if you draw a straight line from the lower blue point laterally on each side, the intersection between the lower blue point line and the posterior axillary line is known as the Plaps point. The reason why this point is important is you can see certain lung pathologies at this point, all right? And we will go over some examples of what the lung pathologies are. There was another study that was done that showed that if you actually go more posterior to the Plaps point, you have increased specificity of diagnosing other conditions. So what I recommend is you get to the Plaps point and just go all the way back, as far back as you can go, all right, to this area. So you get here and then you just slowly go back. Now, this patient, we went to the Plaps point, okay? Over here, we're seeing the liver and the diaphragm line coming in and out of focus. There was nothing there. We just saw a nice normal lung curtain, okay? The Plaps point was negative for any pathology. So let's go back. Patient coming in, dyspneic, tachycardic, tachypneic, that had lung sliding. They had A-lines in bilateral lung fields. You scanned, there was no DVT. You looked at the Plaps point, it was negative for any pathology. this patient could possibly have asthma or COPD. Now let's go over what some positive findings at the Plaps point are. So this is an example of a pediatric patient. What we see here is something that looks like liver. And as we're scanning down all the way, we actually get to the liver. So the liver is all the way at the bottom right here. So when you see something, when you're scanning the lung, that looks just like liver, that is consolidation. The term is called hepatization. So we typically say hepatization because now the lung is looking like the liver. This is a case of pneumonia where the consolidation causes the lung to look more like the liver. Okay. Now, some other findings that we see here are these hyperechoic areas or these bright lines. These bright areas, we will go over exactly what these bright areas are, what they mean, and why this is important in subsequent slides. So that was in a pediatric patient, and this is actually in an adult patient. Here we have what appears to be the spleen. Here is our diaphragm. Here is our lung. Again, we just went over what our normal lung should look like, right? This is looking like a nice homogeneous structure. We should not really be able to see anything or identify anything or what appears to be vessels in the lung. So this is looking more like liver when you're doing your fast exam, and that's why it's called hepatization. So this is consolidation of the lungs. Now, these bright hyperechoic things that you're seeing that are moving in and out are called air bronchograms. Air bronchograms are broken down into two different types. They're static air bronchograms, self-explanatory, they don't move. They're dynamic air bronchograms, self-explanatory, they move. Dynamic air bronchograms move during respiration, hence the term dynamic. When you see hepatization and you see dynamic air bronchograms, this is typically seen in consolidation, hence pneumonia. So you're scanning this patient who comes in with tachypnea, tachycardia, dyspnea, maybe febrile. You see this, your diagnosis is pretty much clinched. There are some other findings that we're seeing here, and we're going to go over those findings and what they're called. All the way at the bottom of the screen, I am seeing the spine, and I'll go over the importance of this finding in subsequent slides. Okay, so as you can see, as the patient breathes in and out, the diaphragm moves. The diaphragm moves down as they take a deep breath and moves back up as they breathe out. And as they're doing that, you can see this bright lines moving up and down. Air bronchograms, like we said, are trapped air in the tissue that are either dynamic or are static. Dynamic air bronchograms are typically seen in pneumonia, and static air bronchograms are typically seen in atelectasis, but you can still see some static air bronchograms in consolidation. So another finding that we can see at the Plaps point is subpleural consolidation. So right here, we're seeing that the pleural line is not nice and straight. It almost appears jagged, shredded. That's called the shred sign. That's the interface between normal tissue and consolidated lung. This is another example where you see that jagged or shredded sign, aka shred sign, between normal tissue and consolidated lung. Here is the same example of what we talked about, dynamic air bronchograms that move as the patient is during respiration. This is another example. Over here, you're seeing those bright hyperechoic objects moving during respiration. So again, this is typically seen in pneumonia, in consolidated lungs, the dynamic air bronchograms. Now, this is an example of a static air bronchogram. So we're seeing all these hyperechoic bright lines. They do not really appear to be moving during respiration. And again, this is a typical finding in atelectatic lungs. So back to our patient. Dyspneic, tachycardic, tachypnic. You throw your ultrasound probe on their chest. They have lung sliding. They also have A lines. You scan their legs looking for DVTs, and they do not have a DVT. However, when you went to the Plaps area, it was positive for pathology like hepatization, air bronchograms that were dynamic, and even some subpleural consolidation. This is typically indicative of pneumonia. So what are some other positive findings that we can see in that Plaps point? One of these findings is a pleural effusion. So again, this is our diaphragm. Over here, this structure that looks like the liver is actually the spleen. You can see here, we're in our left upper quadrant, and it's small and not as big as the liver. This hypoechoic dark fluid structure right here is the pleural effusion. And the little thing that was flapping in it is the lung that was flapping in the pleural effusion. So now this is using our linear probe, seeing the same thing, rib shadow. This is a pleural effusion. It's a simple transudative pleural effusion, and we're seeing a little bit of lung flapping in there. This is another example of the same thing. A little bit of lung flapping in a simple pleural effusion. Now, we went over simple pleural effusion, simple transudative pleural effusion. So now let's go over what an exudative pleural effusion will look like. Exudative pleural effusion has the appearance of dust seen during a ray of sunshine. So just imagine yourself in a dusty room. The curtains are partially open. That beam comes through the curtains. These hyperechoic things that you're seeing that look like dust motes in the air is what the appearance of what an exudative pleural effusion looks like. So this is another example. Look at all these beautiful swirlies. Look at all these beautiful ultrasound equivalent of dust motes in the air. So again, diaphragm. This nice hyperechoic thing that you're seeing is the spine. We're going to go over what the importance of that is. And now we've gone over simple exudative and transudative pleural effusions. So now we're going to go over what a complex pleural effusion looks like. I mean, that looks nasty, like, right? Look at all these septae, all these different lobules. That is an example of what a complex pleural effusion looks like. Again, we have the diaphragm here. We have what appears to be the liver or the spleen here. This is the spine, and we're seeing the spine also above the diaphragm. And all we saw is nastiness. When you see nastiness in a pleural effusion, that's just a complex pleural effusion right there. This is another example. Actually, this is an example of what's called the spine sign. All right. Why it's important is when you're typically doing ultrasound evaluation of the lungs, above the diaphragm, we usually do not see the spine. So you see the spine below the diaphragm. This appears to be the left upper quadrant. All right. So you should see the spine, but the spine stops at the level of the diaphragm. When we see the spine above the level of the diaphragm, this means that the ultrasound waves was given a better medium. Remember, air is the enemy of ultrasound, right? So air just disperses the ultrasound waves, and that's why normal lung just looks like schmutz. But when you're able to see a good picture where the ultrasound waves is transmitted to the point where it lights up the spine, it's because the ultrasound beams have a better medium to pass through. Okay, so we typically see it in things like consolidation, pleural effusion. That's why we're able to see the spine in this case. This is, again, another example. Diaphragm, we see an effusion here, and then we see the spine above the diaphragm, which is typically called the spine sign. Again, another example of the spleen. This is the left upper quadrant, and we see the spine above the diaphragm. All right. We went over the difference between the lung preset and the abdominal preset. If you just look at these two different images at the Plaps points, this looks really gritty, whereas this looks crisper. Just watch the videos play, right? This is what normal lung should look like. Just schmutz. We're not really seeing anything in there, right? And if you notice, I'm seeing the spine again up until the level of the diaphragm, but I can't see it past that. Now, look at the same thing using the abdominal preset. Nice and beautiful. I'm seeing the spine and it's stopping here. So again, this is a negative Plaps eval, right? Plaps negative. But if you're looking for an effusion, sometimes the abdominal preset is better because it gives you better and crisper image quality. All right. So sometimes switching to the abdominal preset is better than using the lung preset, depending on what you're looking for. So now back to our blue protocol. We've gone over diagnosis of pulmonary edema and PE. While we're on the subject of PE, I showed you a subpleural I showed you a pleural wedge. Pleural wedges in PEs are not things that we typically see. All right. We diagnose PE a lot of other different ways. Finding a pleural wedge is not really easy. Sometimes asking a patient where it hurts, and while you're scanning there, you can see a pleural wedge, but it's not something easy to find and it's not that common. So just take that into consideration. Now we've also gone over the Plaps points being positive, talking about pneumonia, and the Plaps being negative, talking about COPD or asthma. So we're going to then translate to this portion of our blue protocol. Let's go over the AB profile. The AB profile is when you scan one portion of the hemithorax and you have a wonderful A profile. There is lung sliding. You're getting nice A lines, okay? And then you're scanning the next hemothorax, the next hemithorax, and you see some isolated B lines that then come into view, right? Going all the way to the bottom of the screen. So one part of the lung, perfectly fine. Beautiful A lines. You go to the other side, A lines, A lines, A lines, and then you're like, what else? What's up with all these B lines that are coming into focus? This is typically indicative of pneumonia. Okay. Now let's get into pneumothorax. All right. So a pneumothorax is when there is no lung sliding at that pleural line. All right. So that is when the parietal and the visceral pleuris are not touching. So because of that, you do not have that motion artifact along the pleural line, or you do not have the ants marching down the screen at the level of the pleural line. So this is another example. Looking at the pleural line, no motion artifact, no ants marching down the screen. Note, I'm still seeing reverberation artifact, indicative of an A line, but nothing moving here. Same thing here. I'm not seeing the ants marching down the screen. I'm seeing rib shadow, nice pleural line, but no motion artifact across that pleural line. So that is typically indicative of a pneumothorax. In these cases, it's simple, it's easy to see, all right? However, there are cases where the quality of the image is not as well, or you are not sure. You're like, I think I see motion, but I am not sure. What do you do? This is where we use the M mode again. So we hit the button, we generate that nice vertical M mode line. We place it across the pleura, not on the rib. So right in the middle of that pleural line, we hit that button again, and it generates this motion artifact over time. So here we're getting nice horizontal, just straight horizontal lines. If we look here, this is about 4 centimeters in depth. The pleural line is approximately about 2 centimeters, which is roughly here. The area above the pleural line looks the same to me as the area below the pleural line, just nice and horizontal. There is a name for this. It's called the barcode sign. This is another example of it on an actual patient where the area above the pleural line is exactly the same as the area below the pleural line, just nice, straight, horizontal lines. This is typically indicative of a pneumothorax. So again, you use M mode in these situations where you are not sure, you can't really tell whether there's motion artifact or not. This is another tool in your toolbox to be able to appropriately diagnose a pneumothorax. Now, this is an example of using M mode where you have normal lung sliding. You have that nice gritty echo texture below the pleural line, contrasted to just that same nice horizontal line indicative of a pneumothorax, just for you to have side-by-side comparison. Now that we've gone over a pneumothorax, it's important to know what a lung point is, because this is something that really increases the specificity of a pneumothorax. When you don't see lung sliding, you likely have a pneumothorax. When you see a lung point, there's 100% chance that you have a pneumothorax. Or you may have a pneumothorax when you see no lung sliding, but when you see a lung point, you definitely have a pneumothorax. The importance of understanding the differences between both of them is there are other conditions that present with no lung sliding. So these conditions can potentially abolish lung sliding. Examples of these conditions, we've already talked about. One, pneumothorax. In ARDS, you can also have no lung sliding. In pulmonary fibrosis, you can have no lung sliding. And in a particularly large consolidation, sometimes you can also have no lung sliding. Okay. So this is an example of a lung point where you see it coming in and out of the screen. This is another example here of a lung point where you see literally the lung sliding is here, whereas the area of the where there was no lung sliding is past that point. So the point at which the lung sliding meets the area of the no lung sliding is called the lung point. You're going to see another example here, moving in and out of focus. That tip of the area between where there is lung sliding and where there is no lung sliding is called a lung point. Now, depending on how large the pneumothorax is, it can be hard to find the lung point. But again, you're taking all your context clues and your clinical context into account. Okay, but once you see this lung point, it really increases the specificity of a pneumothorax to 100%. This is another example of the lung point that comes in and out of focus. Okay. Another example of the lung point that comes in and out of focus. Now, if you throw the M mode line down, you'll be able to see as the lung with actual sliding moves past that point, you'll be able to see it as this nice gritty echo texture that we talked about, indicative of lung sliding. And then after that, we have our nice horizontal lines indicative of no lung sliding and the hemothorax. So this point between where there is normal lung sliding and no lung sliding is called the lung point. So back to our patient. Our patient who is dyspneic, tachycardic, tachypnic, who has no lung sliding, does have A lines. Okay, we do see a lung point. What's the diagnosis? You got it. The patient has a pneumothorax. Now that we've gone over the concept of lung point, it's important to discuss the concept called lung pulse. I know I'm giving you all these names that are really similar to each other. Now, lung pulse is important to know because a lung pulse means there is no pneumothorax. It rules it out. A lung pulse is motion artifact from the heart that comes to the lungs. So we have this nice gritty echo texture once we put our M mode. So we know that there is lung sliding, okay? However, you can see that there are areas of almost like a nice vertical band that is coming down through our gritty artifact. This is the lung pulse, which is just motion artifact of the heart beating that goes to the lung. On the left side, they're more organized, but as they travel to the left side, the right side, they're less organized. And any questions? I'm happy you guys, bore with me through the slide. If you have any questions, please feel free to reach out to me.